Good afternoon, all, and thank you so much for joining us today for this Hepatitis C Elimination Community of Practice webinar. We are thrilled to have you all here today to hear about some really incredible work that's happening in hepatitis C elimination, with a particular focus on prisons and jails. Before we jump into the webinar, I wanted to give a little bit of background for those of you who are perhaps a little bit newer to INSU and the work that we do. So INSU stands for the International Network on Health and Hepatitis in Substance Users, and we are a not-for-profit member-based organization who is dedicated to the health and well-being of people who use drugs. We have three key pillars of work. Firstly, knowledge exchange, under which sits our annual conference, this year to be held in Cape Town in South Africa. Education and training, we run a suite of education and training programs since about 2016, and policy and advocacy work. We're governed by our members and our board, and our programs are carried out by the INSU Secretariat, who are based in Sydney in Australia. So a few acknowledgements before we begin. This program of work has been developed by INSU, but in really close collaboration with our partners, the National Alliance of State and Territorial AIDS Directors and the Coalition for Global Hepatitis Elimination, with whom we have worked on this program since 2022. I'd like to also extend our thanks and acknowledgement to our endorsing organisations and endorsing collaborators who have worked with us across the program's delivery. And a big thank you also to our sponsors, AbbVie and Gilead. We're very grateful for their support in enabling us to put on our in-person and our virtual events. And you can see up there our sponsorship policy is listed on the screen. A bit of background in terms of how this community of practice was formed. A number of years ago, INSU, in collaboration with local partners, developed a hepatitis C intervention toolkit. And this digital toolkit profiles a range of different interventions which have been demonstrated to enhance the Hep C care cascade. So interventions like dried blood spot testing, point of care testing, care navigation, peer support, etc. And you can access all those how-to guides for free on our website. They're accompanied by a range of best practice models of care infographics and a series of films showcasing innovative models of care from around the globe. The how-to guides provide really sort of practical information as to how to actually set up and scale up these interventions in your service. And they look at different best practice examples, different challenges, barriers you might experience in implementation, how to overcome these, and provides a really solid evidence base for their implementation. However, the toolkit was always very much intended for a global audience. As we know, the challenges for implementing interventions are different, not only country to country, but city to city and service to service. And we really wanted to provide people with the opportunity to come together locally to discuss some of the barriers and enablers that they are experiencing when it comes to their hepatitis C models of care. Subsequently, in collaboration with an incredible committee, we developed a one-day in-person, highly interactive training program to support people to either develop or to enhance their own models of hepatitis C care and build connections with other providers. The audience of these symposia is highly multidisciplinary, so a range of different healthcare providers, physicians, frontline workers, nurses, programmers, policymakers, etc. The aforementioned steering committee is up there listed on the screen. I'd like to extend again a massive thanks for all of their work across the program's development and delivery. We began piloting this program in 2022 in the UK and Canada, followed by the US in 2023, Portugal in 2024, and Australia in 2025. Since the inception of the program, we've delivered 20 symposia to almost 900 attendees, as per the breakdown listed up there on the screen, and we've delivered 2 community of practice webinars in the US to 167 participants. So this community of practice you've joined today is intended as a follow-up activity to the in-person symposia to support sort of ongoing troubleshooting and collaboration building. It is also intended as a way to be able to involve folks in hepatitis C education training that may not be able to attend one of the in-person symposia. And the topics that we choose are very much guided by the symposia participants, our local stakeholders, and our committee. Previous webinars that we've delivered have looked at post-symposium impact in terms of surveillance, policy changes, and also street medicine. So time to introduce our incredible presenters for today. I am thrilled to introduce Carla Thornton, the Interim Executive Director for Project ECHO and Professor at the Division of Infectious Diseases for the University of New Mexico Health Science Center. Captain Chad Garrett, U.S. Public Health Service, Health Program Manager for the Prisons Division at the National Institute of Corrections. And Jean Schexnayder, Corrections Coordinator at the Louisiana Office of Public Health STD HIV Hepatitis Program. A very brief overview today. I'm going to pass now to Carla Thornton, who will deliver her presentation on peer-led education programs in prisons in New Mexico, before we'll hear from Chad around engaging correctional staff in the delivery of Hep C care, and finally, fortunate to hear from Jean on the delivery of Hep C care in parish jails in Louisiana. So without further ado, I'm going to pass to Carla, who is going to present for us today. Thanks so much, Carla.
Thank you very much. Are you going to give me slide controller?
Yes, it's just buffering.
Okay,
It's coming
thank you.
right now. There you go.
Excellent. Hi, everyone. My name is Carla Thornton. I'm really excited to be here today to talk to you about the work that we've been doing in the New Mexico prison system for a couple of decades now. I also just want to thank INSU and thank you for the opportunity to speak, and just the work that INSU is doing around the world is really, really important. So I'm glad to be a part of this. I have nothing to disclose. So I'm going to talk about our work in New Mexico and the prison system. Like I said, that's been going on for quite some time. We have, for those of you in the US know that we have a really big problem with hepatitis C in our incarcerated populations. And the incarcerated populations have about a 9 times higher prevalence than the general population in the US. We also incarcerate a lot of people, and we have a lot of people spending time in prisons and jails. So almost 30% of all people with Hep C in the US spend at least part of the year in a correctional facility. In the US, we also, as I mentioned, have a high rate of incarceration. So in 2025, 2 million people were incarcerated in the US. So we know that we have to address hepatitis C in carceral populations to even come anywhere near hepatitis C elimination. This is some older publication by Ann Spalding that it's been known, at least for where the state prisons that have good seroprevalence data, that we have the highest seroprevalence of hepatitis C in New Mexico. We have 11 state prison facilities in New Mexico here in the red, where the red these white crosses are. We have had universal hepatitis C antibody testing in New Mexico since 2009. So we have really good antibody data all the way back starting in 2009. And in 2018, we started doing reflexive HCV RNA testing in New Mexico in the state prisons upon entry. So since that time, we have excellent RNA data. The antibody positivity upon entry into the New Mexico prisons has been 50% since they started checking in 2009. So it's very, very high. Again, we think that there are some prisons who don't test universally, but we think that we have the highest rate of hepatitis C in our prison system. And now we have good viremia data since 2018. So 30% of our population who entering the prison system has active hepatitis C infection. And we got involved with our prison system through Project ECHO a long time ago, which I'll tell you more about that. So the timeline, so around 2003, when Project ECHO started, one of our first partners that we worked with to do hepatitis C treatment using the ECHO model was the Department of Corrections. They were one of our very, very first partners. And during that time, this is the time of interferon, as you all know, so it was much more complicated to treat hepatitis C. So they wanted our guidance with all of the people that they treated. And we would have what was called an ECHO session once a week for an hour, where their providers would come on and learn more about hepatitis C. And then they would present their patients de-identified to us, and we would help guide the treatment of people who were receiving hepatitis C treatment. So that was back in 2003. From 2003 to we get to the peer education project, which I'm going to talk about, I was really, really frustrated because we were treating just a handful of patients, and I would hear about somebody almost on a weekly basis who clearly had acute hepatitis C infection. Their liver enzymes would be very, very high. They had been negative when they came in. And I just thought to myself, what do we do? We need to do something else besides treat a few people. We need to actually get into the prison system and do some education around Hep C transmission so that we can give people the tools to protect themselves from getting infected. So around 2009, I was looking for models in other states that I could replicate in New Mexico. And I found a really interesting model in Texas called Wall Talk that was focused on HIV. And they did a very similar, to what I'm going to describe what we do, but they would train peers for 40-hour training around HIV and STIs. And then the peers would be the ones who would do the education, the HIV education in the Texas prisons. So we took that model and changed it a little bit and made it our own and really focused on the things that are most prevalent in the New Mexico prisons, which are hepatitis C and addiction. So it focuses a lot on hepatitis C and addiction. We started that in 2009, and I'll talk more about the details of that. And then something important happened in 2020. Our legislature allocated $20 million for Hep C treatment. Prior to that, there had been very little money that was available for Hep C treatment. So we really ramped up treatment of hepatitis C in 2020. And they partnered with our Department of Health to obtain 340B pricing for hepatitis C medications. So we helped them and collaborated with them to ramp up hepatitis C treatment. So our New Mexico Peer Education Project has several components. So we do a 40-hour training, which I'll talk a little bit more about. We go into the prisons with our team and train usually a group of about 15 people in the prison to be peer educators. After that training, they do their own workshops. They do 10-hour workshops or shorter workshops, training other people, their peers in the prison to more about a lot about hepatitis C and other things, which I'll talk about in a minute. And then we have a bi-weekly echo session. So twice a month, they come on, all of the prison peer educators come on through Zoom in their groups, and we do ongoing training. They do a case presentation which is following the echo model, where they'll present something that it's not a patient case, it's more of an issue that's going on within their peer education group that they want input from the other peers. And then my team will do monthly follow-up with the peer educators, either by Zoom or in person if they're close. So these are a couple of pictures of our 40-hour trainings. As I mentioned, we go into the prison with a team. Our training team, Carissa McGee and Daniel Rowan, are the two senior managers of these programs, and they were formerly incarcerated. I met them when they were incarcerated, and when they were released, we hired them basically, and they've risen to the top of the program. So they're now leading these programs, and most of the people that we've hired to work with this program have been formerly incarcerated themselves. So these are just pictures of the graduation of after 40-hour training. The peers are selected. They usually they are selected by the wardens. We don't go in and just choose who we want to be peer educators, but they have to have some minimum criteria here. They have to have at least an 8th grade literacy level. They have to have at least a year left on their sentence, because we want them to be able to be trained and then to be able to educate before they leave the prison. They have to, they have to have demonstrated some informal leadership in the prison, and that usually comes again from the warden. They have to be interested in public speaking, because they do a lot of it. That's basically what they do. So if they don't want to do public speaking, they really shouldn't become peer educators. And they have to fully participate in the 40-hour training that we provide. These are the things that we go over, that we train about. We train the peer educators during the 40-hour training. We talk a lot about hepatitis C and harm reduction. And again, they work on their public speaking skills during that time, and they will present to each other and to us. We also go over all of these other things that are listed here on this slide. And then, as I mentioned, they do the peer-to-peer workshops. So these are our peer educators who are doing a workshop for their peers. And, they don't have access to PowerPoint slides or anything like that. So they have to draw all of their, all of the artwork that they use to teach about to teach their classes. So they become very creative. And what we focus on are what we call the 5 questions. So the 5 questions about any infectious disease that you can apply to any infectious disease really are here. How do you get it? How do you know you have it? Can it be treated or cured? What can happen if you don't get it treated or cured? And how do you prevent getting it or giving it to others? So when they're training about any infectious disease, including hepatitis C, they go over these 5 questions. We also talk to them a lot about hep C testing and treatment, which they talk to their peers about. And we also talk about reinfection because we've seen quite a bit of reinfection in our system since we started treating. This is a picture of one of the echo sessions. As I mentioned, all of these are the peer educator groups. So this is my team down here. And we usually often will have, almost always have the Department of Health on as well. And they'll give a little update about what's going on with around the New Mexico from the Department of Health standpoint. And the regular follow-up is mentioned. They are either in person or they do it through Zoom. So I'm not going to go through all of these numbers, but we've educated thousands and thousands of people. We have trained over 1,000 peer educators since we started the program 15, almost 16 years ago now. We've done many, many 40-hour trainings. During COVID, they had to shift a little bit, so they couldn't do these larger workshops. They had to do like one-on-one. They had to do very small workshops with very few people. So things changed during COVID, but it's back to where we were pre-COVID, and they're doing a lot of continued training. And this is just a slide showing you what I was mentioning. So we were involved in this hepatitis C treatment very, before 2015 even, but these are the number of people who are receiving treatment even after the DAAs were released in 2014. So very few people were receiving treatment until 2020 when we ramped up really dramatically, and last year treated almost 1,000 people for hepatitis C in 2024. And it'll be high, it'll be at least 1,000 in 2025. Some of our challenges are people do refuse treatment. Many people refuse their SVR labs. Most people do not get their SVR labs drawn. And there's a lot of reasons for that, but the peer educators are actually really important in addressing these issues. So we talk to them about this a lot too. And if someone refuses treatment or refuses their SVR labs, the medical providers will ask them if they will suggest that they go to one of the hepatitis C peer education workshops, and they will also just tell them that maybe they should talk to one of the peer educators. So our peer educators have been active in trying to encourage people to get their SVR drawn and also to talk to them about reinfection, because a lot of them will think that if they got reinfected, they're not going to be able to get treatment, but we are treating a lot of reinfection as well. So we have a little bit of preliminary data looking at people, the people who have actually gone to the peer workshops are more likely to get their SVR lab drawn, and they're less likely to refuse treatment. So we definitely think that the peers are having an impact in both of those areas. And lastly, I just want to mention because of the work that we've done in the prison, our corrections department came to us asking us to start a peer education project on the outside. So we started CPEP, the Community Peer Education Project, probably 3 or 4 years ago now. And we have people who are peer educators. These are all of our peer educators. They're formerly incarcerated and are now out. And now they work as peer navigators with people coming out of prison to help them in many different things that they're needing to do when they get out, but also accessing hepatitis C treatment if they didn't get treated while they're in the prison system. So we're really excited about this program. It's younger than the one inside, but we think they're making a real impact on the people who have gotten out of prison here in New Mexico. So thank you very much. I'm really excited again to share this information with you. If you're interested in learning more, my email is right here. And A couple of people have replicated this project in the United States. The Indiana Department of Health has replicated completely this project, including the CPAP part of it. Tennessee has also replicated the New Mexico, the Inside Peer Education project. So if anybody's interested, we're happy to share all of the information with you and help you in any way if you'd like to do this in your own facility. So again, thank you very much for your time.
Thank you so much, Carla, for that presentation. Just a reminder to everyone, we will have some time for questions, discussion at the end of all three presentations. Feel free to add them to the chat and we will address at the end, or just hold on to them and you can ask Carla any questions at the end of today's session. A big thank you to you, Carla, and I will pass now to Captain Garrett.
Great. Here we go. So, good morning, good afternoon. I am Captain Chad Garrett, and it is an honor to join this global dialogue on hepatitis C. This is a conversation that couldn't be more timely or more vital. Allow me to indulge myself and take just a moment to introduce myself. I cannot be defined as your average nurse, nor your average typical federal officer, and certainly not anyone who's ever colored inside the lines. As I've stated, I do have the best job in the world. I am the health programs manager at the United States Department of Justice National Institute of Corrections, where I provide leadership to the field in a myriad of ways, which we'll go over. I'm a nurse who's been forged in the Army with some battlefield grit, a federal health strategist with a passion for turning policy into practice, and a staunch believer that healing doesn't stop at the prison gates. I've been described as relentless, resourceful, and refreshingly real, and some other things as well, but we'll skip over those. So whether it's building national curricula, launching virtual training series, or championing hepatitis C treatments behind the walls, wherever there's a need, you'll find me there, stethoscope in hand, boots on the ground, and my vision firmly ahead. I'm here today to challenge some assumptions, share some insights, and remind us all that correctional health is central to the foundation of public health. So born in the aftermath of Attica riots, NIC is a federal agency within the Department of Justice founded in 1974 to support state, local, and federal correctional agencies. Unlike most federal agencies, we are not regulatory. We are a center of excellence focused on training, providing technical assistance, and evidence-based innovation. The NIC provides guidance, support, consultation, training, you name it, we've probably done it. The original mission of the NIC was to encourage the development of a body of correctional knowledge, coordinate correctional research, and provide experienced technical resource staff to the field. Our role in health is grounded in the belief, again, that correctional health is community health, and that includes our work with hepatitis C. As the health programs manager, I deliver national trainings on hepatitis, diagnosis, treatment, and linkages to care. These are designed for nurses, doctors, wardens, line officers, depending on the training. There is an emphasis on real-world cases, common errors, and updates on the national guidelines. I like to think of myself as a translator of science into a more correctional vocabulary and a mindset. I have the opportunity to work across agencies like the Center for Disease Control, the Federal Bureau of Prisons, SAMHSA, and all of the state departments of corrections. One of my goals is to break down the silos and create these holistic models of care that address medical needs from incarceration to long after the offenders have left custody. Assisting facilities in rolling out screening protocols, peer education, and care coordination post-release is something the NIC is specialized in. I've also focused in on training staff to avoid clinical pitfalls, as covered just recently in several of our webinars, providing some, we'll call them clinical pearls. One of my current projects is in conjunction with the Bureau of Prisons and the Center for Disease Control in the development of a field guide for STIs, hepatitis, and HIV. We're working on building an easy-to-use reference guide that is truly boots on the ground information for the staff on the front lines, sort of, again, translating the science into more correctional, useful type of information. So NIC is more of a force multiplier. And although we recognize the problems are daunting, there remains a lot of hope. So upon incarceration, all adults and a majority of juveniles lose access to their usual public and private health care and disease prevention services. Their health care becomes the sole responsibility of either the correctional system or sometimes the public health system. However, the rapid turnover of incarcerated populations, especially in jails, and the sometimes suboptimal funding of correctional health and prevention services kind of limit the correctional systems in providing both curative and preventative care. So we know that incarcerated people have a disproportionately high rate of hepatitis. I think we covered that. Despite CDC recommendations for universal opt-out hepatitis testing at correctional facilities, approximately only 11 states mandate routine screening. An estimated 80% of incarcerated individuals with hepatitis remain undiagnosed and untreated. And correctional facilities remain critical public health touchpoints for reaching these marginalized populations, especially people who use drugs and are unstably housed and uninsured. The NIC is here to help provide tools and resources. So I see correctional facilities not just as points of confinement. These are pivotal points of care. For many incarcerated individuals, incarceration is the first time they've had consistent access to healthcare. This creates this unique window of opportunity to diagnose, treat, and interrupt the chain of hepatitis transmission, both behind the walls and in the community. So just a quick story to illustrate the point. Marcus, 36-year-old man with a long history of IV drug use, entered a state prison in 2024 for nonviolent drug offense. Upon intake, no hepatitis testing was offered. Despite occasional fatigue and mild abdominal discomfort, he never sought care, assuming it was just stress or diet or just being in prison. After 18 months, he was released, still unaware of his infection. He rejoined his community, as many do, resumed drug use. He injected with shared equipment several times over the following weeks. So the outcome of that, 6 months after release, Marcus was hospitalized with advanced hepatitis C, contact tracing and testing, and his social network identified at least 4 additional cases linked directly to him. So imagine what could have been different. Where could we have made these changes? If he had received opt-out screening at intake and access to direct-acting antiviral treatment, the outcome could have been so much different. He could have been cured in 8 to 12 weeks. His reinfection risk could have been reduced through targeted education and support. Community transmission would have been interrupted, saving lives and healthcare costs downstream. The problem is that Marcus' story is not rare. It's really reflective of these system-wide gaps. Studies show without testing, the majority of these individuals remain unaware of their infectious status. Without treatment, they return to the community as reservoirs of transmission. And without interventions, prisons can become pivotal points of public health success, not failure. So again, incarceration shouldn't be thought of, it should be thought of a clinical opportunity, not a missed one. So how is the NIC being leveraged? Again, we're developing standardized training curricula for custody, clinical, and administrative staff. We're using the NIC's national platform to normalize screening conversation and highlight correctional facilities as opportunities for public health interventions. We issue evidence-based policy templates for routine hepatitis screening, diagnosis, and linkage to care. We try to align protocols with the CDC, the NCCHC, and Department of Justice standards, making compliance easier for facilities. We have expanded interdisciplinary training for correctional healthcare teams. That is both healthcare workers and our non-healthcare workers as we go forward. We facilitate partnerships with state Medicaid programs, pharmaceutical companies, and public health agencies to reduce drug costs and increase access to the medications. We are working to develop national benchmarks and dashboards for correctional hepatitis screening and treatment rates so that we will be able to actually have some numbers to work with. One of our main missions is promoting research on the treatment adherence, reinfection prevention, and post-release continuity of care. We support facilities in using quality improvement cycles, plan, do, study, act to track their success. We pilot transitional care models that ensure hepatitis positive individuals continue therapy after release. And I'm a huge advocate for electronic health records. It's still hard for me to believe in this day and age, we have so many places that are still paper and pencil or pen. So I feel that that really can bridge that custody and community care and reduce those treatment interruptions that we see all the time. We act again as a national researcher, educator, and standard bearer. It really is the slowest slide transition. Oh, there we go. All of that to get to this important slide. So here's my contact information. At the National Institute of Correction, we are always looking for ways that we can help the field and become that force multiplier. I'd like to say that I am from the government and I am here to help. And with that, I will pass the mic.
Thank you so
Thank you,
much.
guys.
Thank you, Captain Gatt. I'm sure folks have a bunch of questions for you, which we will come to after the next presentation. I know I definitely have a couple of questions for you and very excited to watch the progress of both the field guide and the dashboards. They sound like incredibly valuable resources, but we'll come back to discussion after the next presentation. So I will pass now to Jean. I will just move through. Hopefully you'll be able to move through the slides yourself at this point, Jean.
Hello, my name is Jean Scheck-Snyder. I am the Corrections Coordinator with the Louisiana Office of Public Health. I'm with the STD HIV Hepatitis C program. And for this presentation, I'm going to refer to our office as SHIP. So I'm going to talk to you today about the Hepatitis C elimination program that is happening at the Department of Corrections, but at the parish, we call them parish, at the county facilities. So our objectives is to learn the collaboration history between Louisiana Office of Public Health, SHIP, and the Louisiana Department of Corrections, to gain knowledge about the hepatitis C elimination program at our county jails, and to use information to implement this hepatitis C elimination program at other county jails. So SHIP and Department of Corrections have a long history of supporting testing and medical release planning at the state level. Our partnership dates back to about 2006. In the early days of our partnership between SHIP and DOC, we supported screening for HIV on intake and at release. Then in 2019, Louisiana adopted its plan to eliminate hepatitis C by screening the entire population of Department of Corrections at our 8 state facilities. So we were screening for HIV, hepatitis C, and syphilis. So we weren't having just screenings on intake and release. We were now going in and screening the entire population. The population screening is conducted by mobile phlebotomists that are employed by SHIP, and Department of Correction staff screen upon intake and on discharge. So what makes this program so unique is Louisiana is the first state in the nation to ever do this type of mass screening within a correctional setting. And since we have started doing this in 2019, I'm very excited to say other states have also implemented these screenings. We started the screenings in 2019 at our 8 state prisons. And then we started screening at parish level in 2021, and that continues today. And we are finding a lot of our parish jails are now screening on their own. And again, this is a collaboration between the Louisiana Department of Corrections and the Louisiana Office of Public Health. So when we look at our population of individuals who are in state custody, this was back in earlier in 2005, we had over 29,000 individuals in state custody. But when we look at where they're housed at, we have about less than 50% of those individuals are housed at a state facility. The majority of those individuals are housed at parish/county jails. So again, over 50% of this are housed there. So what are we screening for? We are screening for, so Department of Corrections, when someone comes into the DOC system, they are screened for hepatitis C, HIV, and syphilis. Where the focus is identifying and treating those who are living with hepatitis C. So those are what we screen for. We screen individuals who are housed at who are DOC, housed at county jails, who have a release date greater than 30 days. Also for this screening, we worked with a lab company to create what we call custom panels. So when we go to order these labs, we just have to enter one code and it'll pull up all the tests that are associated with that screening. So this is kind of a scenario, we have three scenarios of how the screening is currently working at our county jails. The first one is what we call the mass screening. Well, we'll reach out to a parish jail. We let them know we'd like to come in and we would like to screen the DOCs that are housed there. And what we have learned is what works in one parish may not work. What works at one county may not work at another county. What works at one dorm may not work in another dorm. So we really work with the jails to come up with a custom plan of how are we going to accomplish this goal. One of the things we learned pretty quickly is we need to do, when we do our site visit, we do an education component where we go in and we literally going dorm by dorm, explaining who we are, what we're doing, and what we're screening for. Because we learned if we don't go in and tell individuals what we're screening for, there's going to be lots of rumors about who we are, what we're doing. So again, we come in, we educate, then we do the screening, and depending on how long, how many individuals are there, what they can support, our screenings can take, sometimes 3-4 weeks at each facility. The labs are reviewed by the DOC provider, and then they are returned to the facility. Individuals that we find that are living with hepatitis C, we schedule a telehealth appointment with the DOC provider, who's a nurse practitioner. From there, once she meets with them, she will write the prescription. Medication is ordered and shipped directly to the facility. We request that the individual is released or transferred, that medication goes with them. From there, we're able to track, and in 12 to 12 weeks of post-treatment, we come back in and we do those SVR12 labs. So this is our first scenario of the mass screenings. And then our second type is what is called rescreenings, because we realized if we went into a jail in 2021, the population has completely changed. So we are now going back and rescreening some of the county jails that we've already screened at. Again, we work with the facility to develop a plan for the facility. We do the screenings. The labs are reviewed by the provider. They're returned to the facility. Telehealth is scheduled. prescription is written, and then we do the 12-week follow-up. One of the things we really work with is security, because we have to coordinate with this with security. Sometimes when we're doing call-outs of 20, 30, 40, or 50 individuals, that's going to require additional security staff on hand. So we really have to work with each facility to make sure that we have enough security in order to do this safely. And then this is the third way. We have found that the jails are now screening on their own. This is like an individual comes in and self-reports, or if an individual goes to the hospital and they're screened at the hospital, and then the facility is informed that this individual is living with hepatitis C. So anyway, the facilities will submit the patient information to us. They will, yes, they're eligible for the screenings. The facility will run the labs. Once the labs come in, we have a referral form that they fill out the referral form and submit those labs to us. And then from there, it's kind of the same thing. We schedule a telehealth with our DOC provider. Once they're seen, the prescription is written and the medication is shipped directly to the facility. We track those individuals, and then 12 weeks later, after post-treatment, we will go back and get SBR12 labs if they're still there. Some key takeaway: HIV screening led by LDH, Office of Public Health, for eligible DOC inmates is available. The Louisiana Department of Health covers the cost of the screenings, and Department of Corrections provides the medical provider and the cost of the HIV medications, HCV medications, sorry. This is a strategic partnership and collaboration between state departments, improve the health outcomes of those living in correctional settings, and county correctional staff learn about the benefits and screenings of treatments. And this is my contact information, and my coworker Catherine. This is her contact. She's an amazing data. We couldn't do this program without data collection. And so if you have any questions, that is our contact information. Thank you.
Thank you so much, Jean, for that presentation. We have some time now for questions, discussion. I know I definitely have a couple of questions for each of our presenters, but we're actually quite a nice sort of intimate group today. So if anyone has any questions for our presenters, please feel free to stick your hand up and take yourself off mute and ask your question directly. I'll give everyone a couple of minutes to have a think about their questions, and then I definitely have a couple myself. Any questions from don't be shy, it's a friendly group. While you're all thinking, I might start. I have a question for you, Carla. So you mentioned sort of some of the challenges that are experienced around treatment, sort of reinfection, etc. I'm really interested from the perspective of the peers. What are some of the key challenges that have been noted by the peers themselves, the peer educators, in sort of developing this program? What have they noted as some of the key challenges experienced, and then sort of what were the, I guess, key enabling factors that have helped overcome those particular challenges in delivering Hep C care?
Yeah, that's a great question. I mean, I think that sometimes at some of the prisons, all the prisons are very different, as you know, and the different levels of custody and all that. But when they have a hard time getting people to come to their education sessions, they've just done really creative things to try to make them really, really fun. For one thing, they always have coffee. I mean, they always have the things that, things that people would like to have. They also have changed the times of them. They've changed the duration. They've just sort of really responded to the community. If they've done, instead of doing them in the evening, they'll do them on a Saturday. So they really, as long as they can do it within the confines of what they can actually do, they'll be just as adaptive as possible but those are some of the things, like the time of it. They also will just do one-on-one. Like if someone doesn't, they'll come to them and say, I don't really want to go to the sessions because but I'd like to talk to you about, about how to access hepatitis C treatment or something like that. So they're very, very flexible in what they do. I guess I would say that's the main thing.
Mm, yeah, fantastic. And Chad, sort of from a correctional perspective, do you have any sort of advice for either healthcare providers, administrators, anyone working in these settings in terms of engaging correctional staff wardens in the delivery of Hep C care? What sort of advice or what messages, what messaging, what top tips do you have for sort of working with or engaging with the correctional staff in this space?
So one of the things that I found is that you've got to find out what's important to your executive staff and the custody staff. I have found with my executive staff, if I can translate it to money, that is excellent. If I can tell them they are going to save dollar bills, they are very excited. The other thing that I have found to be very unique among my executive staff is they're very competitive against each other. And if I tell one of my executive staff that if you do this, you are going to be the coolest, you are going to be the person who's at the cutting edge, everyone else is going to be far behind you, they are a lot more likely to go, oh, well, I definitely want to be first. And then that kind of sparks that competitive nature I have found with a lot of our correctional systems. Custody, they can be a little bit more difficult. We try to do a lot of very simple education programs to kind of remove that stigma. But getting some of the old crusty custody staff to jump in with both feet can be very difficult. I find that it oftentimes takes a long time and sort of like Chinese water torture, just one drip at a time. And eventually they will sometimes come over.
Great tips. Thanks so much, Captain Garrett. And then a question for Eugene. Oh, actually, a couple of questions. That 30-day, greater than 30-day cutoff period. How did you land on sort of that 30-day number in terms of access? And then oh yeah, you go.
So the 30-day is, we realize if we screen someone, if they're being released within 30 days, that doesn't give us enough time to have their labs reviewed and to inform them of this diagnosis and to get them started treatment. So again, that's why we have that 30-day, but we also let them know that if they're not able to be screened, if they're being released and they're not being screened through us, this same program is available on the outside through the Medicaid, the Louisiana Medicaid hepatitis C elimination program. So we let them know, if you're not screened with us, when you go home, you can get screened through that program.
That makes absolute sense. And then I guess my second question is in some ways similar to my question to Chad. You mentioned sort of those relationships with security. How, from your perspective, how do you build those relationships with security? Their particular sort of strategies that you employ to develop those relationships? Any top tips for folks on the call?
I think for us, it's helped having the Department of Corrections like when we do our initial emails to the parish saying we would like to come screen, we worded that the Department of Corrections has asked for us to come into your facility to screen the DOCs that are housed at your facility. So it's like, oh, DOC is asking us to do this. It's not LDA, it's not the public health that's wanting to do that. And we've had some resistance. But I think once they see that we are actually there to help find individuals and to get them treated, and also that's like, okay, we're excited to have them there. And we also let the security staff know our goal is to get in and out as quickly as possible. We let them know, hey, we know we got to come in after breakfast is served, but we got to be done before the next count. So we're only there in their facility for 2-3 hours at the most at a time. And so I think what the security was initially thinking is like, we were going to be there all day. And we're like, no, we're just here for a quick window and we're out. We've also let security, we can tell them, like, if we're scheduled to come in and y'all recognize that it may not be a good day. There may have been an altercation. Please let us know and we will cancel screening for that day. So once security sees that we really are working with them to have a plan that works for their facility, that has helped.
Yeah, fantastic. Great tips. I know, Chad, if you wanted to comment, I see you take yourself off mute.
Yeah, I was just thinking one other thing that I've done that's been very successful for bringing corrections into our group is I actually invite corrections into all of my medical work groups. So like the field guide I'm working on with the CDC and the BOP, over half of us as a group are correction staff. I've got everything from a line officer at a small county jail to an administrator at huge prison systems. So with all of them having their voice as part of it and their ownership as part of it, the other correctional officers seem to appreciate it more coming from their peers.
Yeah, absolutely.
You
Great,
know,
great tips.
Another thing that's worked for us is, although we are Office of Public Health, we attend multiple correctional conferences around the state. So the medical staff sees us at these conferences. We've had us medical staff reach out to us for non-HCV related issues, and we're able to help direct them with that. Our big thing was we were able to help some of our the Narcan program. We're able to link some of our jails to that program. So the staff there really sees that we are really trying to help them, and then they're really are open to us coming in.
Yeah, fantastic. Thanks so much, Jean and Chad. One more question for you, Carla. I think I speak for everyone on this call when I say the numbers are just pretty phenomenal in terms of number of peer educators trained and number of people reached through these education sessions. I know we have folks from a bunch of different states on the call today. Do you have any tips for sort of replicating a similar model, whether it's how to sort of get going or any tips around sort of leveraging to scale and yeah, I guess taking whatever program that they have and scaling it up to be able to see sort of similar positive sort of effects that you guys have seen over in New Mexico? Any tips for replicating?
Yeah, well, there have been a couple of replications of the project. Indiana actually replicated the project, both the one in MPEP and CPEP. I think maybe somebody from Indiana may be on this call, but they replicated. Tennessee also replicated. So we're very happy to work with people who are interested in replicating this project. I mean, we will give them the info. They can use what we use, but we're also willing to help them. Indiana actually came down here to New Mexico, and several people from their Department of Corrections and went to an entire 40-hour training, which was really, really great because they really got to sort of see how it works down here. So we're happy to talk to anybody who's interested in replicating
Fantastic.
and to share the manual.
I'm sure you'll have some people wanting to take you up on that. Any other questions from participants? Feel free to just take yourself off mute. No need to raise your hand. Questions for any of our presenters? No, I will be, just a quick note as well, that I will be sharing the recording to this presentation, to all these presentations and this webinar after today. So do feel free to continue to engage either by sharing the recording amongst your networks, or if you have any questions for our presenters, feel free to email those through to myself and we will field those to the right place. So just a couple of last minute points before we wrap up. I know for East Coast folks, this is probably your last call of the day, so I will be brief in my wrap up. I wanted to talk a little bit about INSU membership. So there are a variety of advantages to becoming an INSU member if you are not already. Most notably is a really great discount to our annual conference. We have some information up there on the screen as well as a QR code, but you're welcome to just email the info at inbox if you'd like more information about INSU membership. Happy to provide. There's also a range of different sort of rates available depending on sort of who and where you are. So happy to provide more there. I'd like to make also a little plug for some upcoming symposia that we are delivering across the states. Very excitingly, symposia to be held in Phoenix in Arizona on the 3rd of October, Chicago the 24th, actually it should say October, Baltimore November 2nd, DC November 7th, running adjacent to AASLD at Cleveland, Ohio early next year. And with the Baltimore conference, it's actually being delivered adjacent to the National Conference on Correctional Healthcare. So if anyone is attending that conference, would love for you to come along to the Hep C Symposium. It's going to be super interactive, very hands-on, and we're very excited. There's still sort of a few places available for all of these symposia, I think, potentially bar Phoenix, but the rest are there's still some spots. So definitely encourage you to check it out. The information is available on our website and you can register at the QR code on the screen, or yes, as I said, just on the INSEE website. And then finally, with these communities of practice, we're very interested in sort of engaging with you all you participants in terms of your own models of care. Very conscious that there's incredible models of hepatitis C care running around the country, which we may not be aware of and we would love to showcase and profile. So if you're involved in a model of care for Hep C and you just think that you have some learnings about that model that you'd like to share, I'll send this QR code and this link out to you all after today's webinar. But if you have an innovative program, we'd love to hear about it, either to profile in the form of a webinar. We also run a number of knowledge exchange activities, sort of written reports and the like. So please do get in touch and share information about your model of care. A huge thank you to our presenters today, Carla, Chad, Jean. A big thank you to you for sharing your time and your expertise. It's just incredible to be able to hear about some of the work that's happening around the country in prisons and jails. Very, very exciting stuff. We will be in touch, as I mentioned, to share the recording for today's event. And yeah, have a lovely rest of your afternoon, everybody, or depending on where you are in the country. Thank you so much for your time.
Thank you.
Thank you.